just a couple minutes after the hour. So we're gonna get started with some of the intro while people are still signing in, and then get rolling with the material that we're covering today. So thanks to everyone who's here. It's great to have you for this lecture, which is done as part of our project supported by the National Institute on Drug Abuse, the NIDA Clinical Trials Network. And this is a lecture series that we're offering as part of our study of the process of delivering technical assistance to hospitals to improve treatment of patients with opioid use disorders. And so this is for those of you who are newer to the lectures or to the study, this is a national study of of this approach to how to work with hospitals to improve hospital-based opioid treatment. And we have 6 hospitals in New York that are participating in it. I suspect that all of you or almost all of you are affiliated with one of those hospitals. And you all are 6 of the 24 hospitals across the country who are doing this work. And we're very happy to be your partners. I'm going to quickly introduce myself and my team. So I'm Jennifer McNeely. I'm the principal investigator for our hub, which is based at NYU in the School of Medicine. And others on the call, I'm going to be leading the lecture today, but oftentimes the person, actually all of the time, the person leading the lecture up until now has been Shane Gallagher, who is a co-investigator and our lead technical assistance person for the study at NYU. Also on from my team are Noah Kravchuk, another co-investigator on the study, Aditya Fawole, who is asking you to put in some information to the chat so we know who's here. And typically you'll see Noah Appleton, who's our project director, and she is happily on vacation today, so we're manning the fort. There is CME credit for today's lecture, and there'll be information about that that will provide the link for how to obtain the credit at the end of the lecture. But Aditya, anything else to say about that for now?
No, that's it. Information will be given at the end. Thank you very much.
Okay, great. So let's jump into some of the so what we're talking about today is I think the lectures up until now have covered a lot of sort of very nuts and bolts aspects of treating patients with opioid use disorder in the hospital, and now we're moving into lectures that are more focused on how to engage and partner with patients who are hospitalized with substance use disorders. So this is talking about general principles and best practices around taking care of patients with substance use disorders in hospitals. As always, just to review, the ground rules for these lectures, please continue to type your name, the hospital, and your role into the chat box, also your email, if you don't mind. And if you're able to turn on your video, that just makes it feel better to be talking for an hour, to know that I'm not alone. And we'll be inviting you also to chime in from time to time today. But do mute your mic if you're not talking. And if you don't see your name on the Zoom chat, please change your name in Zoom so that we actually know who's here.
We're given the list, we just kind of
and we invite you to speak up. If you do, please say your name and your role and your hospital before starting your comments, just so that we can all actually get to know each other a little bit better. since this is a large group, don't share PHI, and know that truly we are all figuring this out, and we invite any questions, even if you're not sure if it's an appropriate question. I assure you that it probably is, and it will benefit all of us to hear it. So please, do contribute. Even though this is a lecture format, I'm going to be pausing and inviting some feedback, but you're also welcome to put comments into the chat or to unmute and chime in. I welcome that. This is lecture 6 of 8. Just to give you a preview of what's coming is the next one is going to be on logistical barriers and post-discharge linkage. And then the final lecture is going to be on harm reduction and overdose prevention. I have no conflicts of interest, and we're going to jump in. So the goals of this session are to talk about how medical systems and the experience of actually being, receiving medical care, being a patient can be traumatic, particularly for patients with SUD or substance use disorders. We're going to talk about some common challenges that our patients with SUD experience when they're engaging with medical care, and talk about identifying and implementing trauma-informed approaches to help with those challenges in a patient-centered way, and then to describe some best practices around pain management in patients with OUD who are in the hospital. And we're going to review some case studies as part of a way of better grasping this material. I can tell you, sort of where I'm coming from myself with this is, drawing on my experience as an addiction medicine and primary care physician, as well as a researcher who's done a lot of interviews and focus groups with patients to better understand what their barriers are to accessing medical care and what their experiences are like. And what I've learned through that is that even when our intentions are good, oftentimes our systems are hostile. And sometimes we, as members of those systems, are intentionally, even though we're not intending it, we are unintentionally behaving in a way that the patients can interpret as being, discriminatory or judgmental. And so just having some awareness about that and a need to sort of actively counter that, prior experiences that our patients may have when they're coming into contact with us for the first time can really help us to provide better care and to establish better relationships with our patients. So we're going to talk first about some of the common challenges in patient experiences and in our experiences as providers. So patients in the hospital often, talk about feeling like it is a highly regulated environment, and feeling like they're sort of under surveillance in the hospital. And it's good and helpful just to keep in mind that our patients, even though maybe they haven't been in our hospital before, they've been in other institutional settings that may have been traumatizing, particularly, jail or prison or in psychiatric institutions. And this experience of being in a hospital bed and not being able to leave can be associated strongly with those prior negative experiences. They often talk about having punitive care parameters. So like if you don't act in this way, there's going to be consequences. One example of that is for patients with experience in methadone treatment, fearing that if they slip and use illicit drugs, that they're going to have their take-home privileges revoked without having a chance to sort of explain themselves or to be treated in a sort of respectful and patient-centered way. And there's just a lack of trust that goes both ways. You know, we are often not trusting as medical providers of patients who use drugs, and they don't trust us either because of prior negative experiences. And often, you know, these are patients who are referred to as being, you know, challenging or difficult, or worse, you know, junkies or drug seeking. But these are all, you know, this language is all commonly, I think, encountered by us when we're taking care of patients. And to be frank, you know, patients who use drugs are often treated in a discriminatory way in hospitals. And this is from a qualitative study that patients, you know, feeling dehumanized or like they're being poorly treated, quote, the minute they find out you're an injection user, the doctors, you can see it right in their face. They change their whole attitude. They don't want to help you. It's weird. I don't like the treatment. I hate telling the doctor I use drugs, hate it, because their whole attitude changes. And this is very consistent with what I've heard, you know, from patients, from my own patients, and from doing interviews where oftentimes, you know, in the research setting, patients feel more able to really say what they mean and how they're feeling, because they're not fearing the consequences of saying it. So, yeah, real strong drivers that make patients be reticent about sharing information, and that it's hard for them to talk about their experiences of using drugs. Racial discrimination is also a real thing that intersects with, you know, the discrimination that's faced by people who use drugs, and there, you know, it leads to mistrust of the medical system, certainly, and that there's discrimination in addiction treatment, and the experiences of being discriminated against by healthcare providers certainly is related to medical mistrust, anticipation of discrimination when seeking care in the future, which becomes a disincentive, you know, for accessing care. So delays in care, just, you know, suboptimal engagement with systems of healthcare that could be helpful, but there's, you know, just a large kind of barrier to get over in order to access those systems and care, and oftentimes, you know, bad experiences that precede that. And we've, yeah, I think all become aware of the racial disparities in medical care in general. And this is highly prominent in opioid use disorder treatment. And it's seen strikingly through overdose death rates, which are rising astronomically fast and faster, especially among Black, but also Latinx Americans in comparison to whites. And treatment rates, especially treatment with medications for opioid use disorder, are much lower among Black patients in comparison to white patients in the US. Black patients are also less likely to be offered buprenorphine treatment in office-based or less stigmatizing settings, and tend to be directed towards, you know, methadone treatment programs instead. And despite this, I think there is, you know, growing awareness of the disparities in OUD treatment and in overdose deaths. But the opioid crisis is still, I think, in the public discourse conceptualized as a white epidemic. And that also can be, can help to keep up the barriers actually that Black and Latinx patients face when they are thinking about treatment and whether they would be welcomed in treatment. The causes of the racial disparities in OUD treatment are complex and multifactorial, but contributors include interpersonal racism, as well as structural racism within our systems of healthcare, human services, and criminal justice. And the hospital is no exception. So there have been studies and an increasing amount of research looking at this, but a couple of examples is a large study of Veterans Administration hospitals showing that Black patients were less likely to access any medication for OUD while they were inpatients in the hospital. And this is something that we can do something about. So increasing access to medications in the hospital for all of our patients who have opioid use disorder can help to reduce disparities and can improve the hospital experience and the treatment that patients receive when they're in the hospital, and also become a first step in potentially linking to ongoing treatment. So that's why, a big part of the reason that we're all here for these lectures today. So I think it's also important for us as providers to understand that patients employ strategies to avoid feeling stigmatized and to avoid the reaction like the patient was talking about in that earlier quote, of providers all of a sudden are changing their attitude or openness towards the patient. And those strategies include delaying seeking care, not disclosing their drug use when they do come in for care. And sometimes that it can manifest as actually minimizing their need for pain medication until it becomes a crisis and more difficult to address. And oftentimes it's seeking alternative services, which may be suboptimal medical care, looking for alternative treatments because they really don't feel that they can trust our healthcare system often. And we as providers experience this too. I think especially providers who work with a lot of patients with substance use disorder or other challenges do experience vicarious trauma by sort of hearing about these really intense experiences that patients go through, and it can get exhausting. And I think we all need to have some compassion for ourselves here as well, that it can be traumatizing. It can also be frustrating, where providers often express that it feels like we're not getting anything done here. I've seen this patient come back to the hospital so many times, and we're always sort of back at square one. And thinking about it as like iterative care, and a lot of that it is wrapped up with stigma. It's also some misunderstanding of the disease condition of substance use disorders, which are part of the definition is that it's a relapsing and remitting disease. And so a single treatment is not going to cure the patient and to keep the condition from resurfacing or developing new symptoms. And there's burnout and low morale and reduced job satisfaction, the providers who work with a lot of people who use drugs will often talk about. But we can counteract that by sort of understanding that it's a thing, why it's happening, and sort of embracing it and being kind to ourselves while we're providing good care to our patients. These are a couple of, I think, telling quotes from, first is from an attending in a hospital. There's a lot of burnt emotions in staff. I think there's a lot of people who feel like, why are we wasting all these resources? They're just going to go out and use again. You're just wasting your time. And the second quote from a patient advocate, I've been here for a long time and I've watched staff struggle with this patient population, the source of stress and distress and pain it caused staff. So these negative experiences that patients have, cause their interactions with medical providers to be suboptimal, and that can generate even more negative provider experiences, and we get into this negative feedback loop where the providers were expecting to have a negative experience with the patient is expecting to have a negative experience with us, and so it feels like we're sort of set up to fail or to do battle before we've even met sometimes. And so, but just to reframe this, we also, since this is sort of a feedback loop, we can turn that negative feedback loop into a positive feedback loop, actually fairly, I won't say simply, but just through some small and conscious actions. So I'll tell a short story about that with the patient, just the first patient who popped into my head when I was thinking about this today. But then invite you all to then talk about anything that you think you can do as an individual or a provider to make a more positive experience for patients. So my story of this is I have a patient who I see as an outpatient who is on buprenorphine for treatment of opioid use disorder. And this is an elderly patient with depression and a lot of anxiety, and was on medication, taking it and consistently running out early of his buprenorphine, and would run out, would feel ashamed, and so not contact me when he would run out of medication because he took it all too early. He wouldn't contact me. He would reach out to a friend who would provide him with some either illicit methadone or other pain medications, and be sort of in withdrawal and doing some self-medicating until the time of his next visit with me. And wasn't forthcoming at first about why this was happening. And I made an automatic assumption in my head that he's probably selling his medications or he's just being a non-compliant patient. But I counteracted that in myself, and I asked the patient, I engaged him it was after we had gotten to know each other a bit, and then I was able to engage him in talking about sort of why he was running out of medication and where that was coming from. And he would get anxious, would get very anxious about something not related to his opioid use disorder, and he would just take more medication, take more of his buprenorphine, trying to get some relief about his anxiety, and was having a really hard time changing that behavior. So I did two things. One was that was simple, is I just started sending his medication, for a weekly pickup from the pharmacy, instead of sending him with, a couple of weeks or 3 weeks or 4 weeks of medication at a time, which is usually what we would do for a stable patient. So having his medication for the week and putting it into, sort of like a pillbox sort of thing, helped him to know, this is the medication that I can take today. And he actually never has needed an early fill or run out early or used, other opioid medications since we made that fairly simple change. But I wouldn't have known to make it, without having that sort of open conversation with him. The other thing that I did that we were able to do because we had that talk is to link him to the psychiatrist, and he's now on medication for anxiety. So that's just, that's sort of my example of something that's actually a fairly simple move that reversed this feedback loop that was really driven by fear and stigma and patient feeling like he couldn't talk to me about what was going on. So just, does anyone want to chime in with like one thing that you can think to do, which could be simple, just to create a more positive experience for patients who you see, especially in the hospital? Feel free to unmute or to put it in the chat. All right, nobody wants to take that one. There's a great one. So thanks, Adam. So share why we do what we do. I think that's a great one, and it should be fairly simple, but we have to remember to sort of explain, and sometimes to over-explain why we're doing why we're doing certain things and what we're doing. And we're going to get into some more of this, some more like skills related to changing this negative feedback loop in the next section. So some of the tools that we can use draw from trauma-informed care approaches. So I want to spend some time talking about that. Before I jump in, has anyone in this group done any special training in trauma-informed care? Maybe just put in the chat yes or no, or if you want to talk about it, go ahead and unmute. But just quickly, anyone done any training in trauma-informed care? I won't put you on the spot to talk about what you learned. ACT, acceptance and commitment therapy, great. And I'll be honest, I'm a general internist. I have some training in addictions, but I don't have any deep training in trauma-informed care. So I'm hoping to do that at some point. Great. So there are some in the group who have more experience with this and some of these techniques, even than I do. So I'm going to go through the material, but also welcome anyone else to jump in or expand on anything that's here. We should have time for that. So just thinking about the patient experience in the hospital. And if you can remember being a patient in the hospital, this should resonate even from that personal experience. But Yeah, for our patients with substance use disorders, there are a number of structural factors in the hospital that contribute to the association with trauma. So past institutional traumas from being in other institutional environments that are evoked by the hospital, incarceration being a huge one. But also, domestic violence experiences or adverse childhood experiences that then are sort of resurfaced when in the hospital and within the confines that they're experiencing as a patient. And it certainly impacts the patient experience in the hospital and their outcomes. So the definition of trauma-informed care, it's a strengths-based framework that's grounded in an understanding of and responsiveness to the impact of trauma that emphasizes physical, psychological, and emotional safety for providers and survivors, and it creates opportunities for survivors to rebuild a sense of control and empowerment. It's a mindful and sensitive approach to caring for patients who've suffered from trauma. And it requires understanding that many people have suffered trauma in their lives, and that trauma, even if it's in the past, can continue to impact many aspects of their life, sometimes in ways that they can't even anticipate. And so the advice is to adopt sort of a universal precautions approach to trauma. As we're familiar with universal precautions in medical settings, say, think about, blood exposure and just sort of treating any blood exposure as potentially having, say, a viral disease like HIV or hepatitis, and taking precautions with everyone and with every possible exposure to avoid it happening, and then to treat it as if it had that the condition. So there are 4 key assumptions to a trauma-informed approach to care. First, a realization that trauma affects an individual's coping strategies, relationships, and health. Second, a recognition of the signs of trauma. Third is having an appropriate and planned response to patients who are identified as having suffered a trauma. And fourth is resisting re-traumatization in the care setting. And that's certainly one that we can pay attention to in the hospital, is how that could re-traumatize patients. One example, just to be concrete about it, is with physical touch. So we are often doing rounds in the morning, very rushed, and essentially just touching patients, examining them without explaining what we're doing or preparing them or asking for permission. So sometimes just saying those simple words, is it okay if I examine you? It's okay if I touch this, can go a long way and help our patients to feel safer. Other strategies are reflective listening, which you may have learned in other contexts, sometimes just through navigating our experiences, our relationships, navigating life. Reflective listening can come in very handy. I learned some of it through motivational interviewing training. But really, it's listening and then reflecting by paraphrasing back what you heard the patient say, sometimes mirroring the language, so repeating sort of a key phrase or some key words that they used. And it shows evidence that you're listening, that you're actively listening, and it can help to check that you're really hearing the right meaning, hearing, and that you're on the same page with the patient. And so that can be very constructive. Creating agency for the patient to the extent possible within the confines of the hospital. So giving them some opportunities to have control over what they do, like walking down the hallway or getting a snack, and involving the patient in decision making when you can. Communicating frequently. So this is going back to Adam's comment, and being transparent. So really, explaining what we're doing and why. And maintaining consistency and reliability, so the patients know that you're trustworthy. I think we've all, especially in the hospital, encountered situations where things escalate into a crisis. Sometimes it feels like you didn't see it coming, but some skills for verbal de-escalation. Obviously, ensure the safety of all, providers and patients, and to help the patient manage the distress, avoiding restraint, since that can obviously make patients feel less safe and can quickly escalate a situation. So whenever possible, avoid restraining patients physically, and avoid just escalating the agitation through our own agitation that it's causing. So this table on the right, I think, is just some good things to keep in mind. You should respect personal space, don't be provocative, establish verbal contact with the patient, be concise, so no lengthy explanations or arguments here. Identify, what the patient wants and how they're feeling. Listen to what they're saying. Agree with them or agree to disagree. This isn't the time to argue. Lay down the law, but also and set clear limits as part of it. Offer choices and optimism, and debrief with the patient and staff, particularly once the most acute elements have subsided. So we're going to now switch gears a bit into case examples, and hopefully this will help all of us to kind of think through this and connect it even more to some patient experiences that I suspect we've all had. So the first case is about stigmatizing language and surrounding acute pain. Jeff is a 67-year-old man with opioid use disorder, injection of heroin, and a history of illicit opioid pill use. He has chronic back pain, psoriatic arthritis, tobacco use disorder, and was admitted to the trauma service with an open femur fracture after a motor vehicle accident. He underwent surgery for open reduction and internal fixation, and he's now on post-op day 2. And the addiction consult service is called in because Jeff is reporting uncontrolled pain and chronic low back pain. So you come in and you take a look at the chart, which the notes document that the concerns that the pain is unwarranted or based in drug seeking. The patient is noted to be a frequent flyer who is non-compliant with medications, comes to the ED seeking shelter. There's worry that giving opioids will worsen their addiction habits and are unsafe, and to avoid short or long-acting opioids. Reference to the patient's choice to keep abusing drugs, and notes saying do not offer buprenorphine or methadone, citing no methadone or Suboxone license. So what does anybody want to pick out one or two elements of this documentation that might reflect lack of knowledge or stigma? You can put it in the chat or speak up.
Drug seeking.
Great. What else? Yeah, so drug seeking is a great one to pick up on. Yeah, it's like, because it's dismissing the pain really before being able to understand what the pain is about, and putting it back on the patient. Talking about a license, that's a good pickup as well. So, do you need a license to order methadone or Suboxone in the hospital? If you're a licensed provider who can can prescribe medications, you don't need a special license. You don't need an X waiver to order these medications for patients in the hospital. Great, they're totally rolling in as they should be. So abusing drugs, frequent flyer, choice to keep abusing drugs, great. So here, let's talk about, I think we picked out sort of the things in text in red are all of the sort of red flag, either poorly informed or stigmatizing language. So let's talk about what we should say and model instead. So language is really important. And this is something that we can control and start the process of culture change through gentle correction and modeling correct language for our colleagues. So what if instead of saying the pain is unwarranted and based in drug seeking, we could say what's actually a more precise or inadequately treated pain. And you could say that the pain exceeds what I would expect for this condition. To say, patients a frequent flyer who is non-compliant with medications, comes to the ED seeking shelter. What we actually know is that the patient is not following the treatment team recommendations for medications. Perhaps they come to the ED frequently, which seems to be grounded in a lack of access to meet their basic need for housing. The patient's choice to keep abusing drugs, it would be more precise to say patient's been unable to interrupt their drug use, or patient has an active opioid use disorder. So I think in all of this, the stigmatizing language is also can create confusion, and just saying what we know to be true in a non-judgmental way is more helpful. And why it's important is language certainly reflects underlying stigma. It questions a patient's motives for seeking care, can frame substance use as a moral failing, not as a medical condition. Interpreting requests for pain control as drug seeking just sort of dismisses them or minimizes the patient's report. It reflects outdated substance use disorders terminology, in particular, the diagnosis of drug abuse. So abuse is not part of the DSM-5 definition of substance use disorders any longer. It impacts the quality of care for our patients. This is a nice commentary from Michael Botticelli, is one of the two authors who was the former drug czar of the US and a strong advocate for combating stigma against people who use drugs. And the quote pulled out here is: "A stigma of drug misuse keeps people from seeking treatment. Words like junkie, addict, and druggie can be hurtful and stand in the path of recovery." And our patients often use these terms to refer to themselves or their friends, and it's been an internalized stigma. We're not here to correct them, but we are here to use the right terms and the more accurate terms, as healthcare professionals. So more just some specific examples of stigmatizing language and the non-stigmatizing alternative, on the left. So instead of, and these I think this is pulled out from the nice website that you'll have a link to at the end of this talk, but these are all things that I think hear frequently, sometimes see documented frequently in medical care settings. So referring to patients as a substance abuser or a drug abuser, and really the correct language is person with a substance use disorder. Talk about addicted babies, or it was born addicted, is that babies were born with an opioid dependency, a physical dependency. Talking about a drug habit or abuse or a drug problem. We should be more accurate in our terminology, talk about substance use disorders or addiction, talk about use or misuse of drugs and risky or unhealthy or heavy use. And those can be more communicative of what the problem is here and what its level of severity is. Being clean, he's clean, the urine's clean. What do we mean by that? We mean that it's abstinent, or there's no drugs in the sample usually. So that's what we should say. And then talking about medications, substitution treatment, replacement treatment, and even medication-assisted treatment, which is commonly used term. It's not really accurate. It's a medication to treat the condition of opioid use disorder, or maybe it's alcohol use disorder. We don't think about, an antihypertensive as a medication-assisted treatment for hypertension. It's a treatment for hypertension. And if patients also make lifestyle changes and lose weight and exercise and reduce their salt intake, it can work better, but the medication is a treatment itself. That's where that comes from. So how can we help? I think we can be ambassadors really of better practices by dispelling myths about patients with opioid use disorder, and especially in the context of acute pain management. So we touched on this in some of the prior lectures, that people with addiction who want more pain medications are often seen as manipulative or drug seeking. But really, if people with addiction, and especially people with opioid use disorder, can have unmet acute pain needs, especially in the hospital. Another misconception is that maintenance medications for opioid use disorder should provide adequate analgesia, and really we need to consider medications for OUD and acute pain management as distinct and different challenges. And so what can you do to support the patients with opioid use disorder who are experiencing acute pain? Treat the acute pain, as well as if opioid withdrawal is playing into it, treat the opioid withdrawal, and sort of separate those two, but cover both. Continuing the maintenance dose of methadone or buprenorphine to avoid opioid withdrawal, which is going to intensify the pain. But recognize that patients may need higher doses of other opioids and at shorter dosing intervals to manage acute pain. And multimodal approaches are also very helpful in many cases. So non-opioid medications, alternative medicine, nerve blocks in some situations. And importantly, to model compassionate and respectful care in non-stigmatizing language, and gently to provide feedback to our colleagues when they are using stigmatizing language that can lead to dismissiveness of the patient's pain. So back to our patient, until the opioid debt is met and opioid withdrawal is addressed, it's going to be really challenging to control his pain. So what we can do is initiate methadone and titrate the dose to address both the opioid withdrawal and cravings. And in the hospital, it's particularly easy to split the dose to optimize the pain management properties that methadone has. And then recommending adequate acute pain control with multimodal pain regimen, including short-acting full agonist opioids, and educating providers that the patient has opioid tolerance because of his pre-existing opioid use disorder, and will likely require higher opioid doses for adequate pain control, and that's safe in this case, even if it's doses that wouldn't be tolerated by another patient. And a pain consult can really pay off when you have access to it. And you could discuss with the patient if he's interested in continuing methadone at discharge, and if he is, to begin schedule an intake with him so that he would be able to continue without interruption of the methadone. And that discharge piece obviously is important to get right, so he doesn't end up in withdrawal before making it to care. The second case is just to focus for a moment on AMA, or against medical advice, patient-directed discharges. So Brian is a 45-year-old male with hepatitis C, ADHD, PTSD, and opioid use disorder with heroin and methamphetamine use. He's hospitalized with bacterial endocarditis related to injection drug use. And he was diagnosed at a different hospital a week ago, but left AMA. And he's now in your hospital. He's considering leaving before completing his recommended antibiotic treatment course. So AMA, or patient-directed discharges, why do these matter? They're really prevalent, particularly in patients who use drugs, and they're very impactful on treatment outcomes. There's a higher likelihood of death, much higher odds of 30-day readmission, and in a patient like this, especially increased infection risk related to injection practices if he leaves the hospital and is with untreated opioid use disorder. And just to step back and look at this, these bullets for a moment, I think if this was another medical condition, the increased likelihood of death and increased odds of readmission, we would be we'd be very attuned to how are we going to ward it off, how are we going to prevent it from happening. And we'd be very focused on treating that condition to avoid these bad outcomes. But when it comes to patient-directed discharges, because of poorly managed substance use in the hospital, it tends to get dismissed. So what could you do in a case like this? First, you start by talking to the patient and listening to them about their reasons for wanting to leave in a non-judgmental way. Try to understand how they understand why they're sick and in the hospital, and think about what you could actually do to support them to make it possible for them to stay. So treating their withdrawal for opioids and cravings, opioids, and don't forget about nicotine, modifying the care plan so to make it a little more comfortable so that they're able to stay, like making arrangements for them to maybe leave the unit in some cases to smoke, or get a snack at the snack machine. Supporting open communication with patients, as well as the hospital staff and visitors. So the patient's concern of nicotine craving, we can provide NRT and have a collaborative approach to help them identify triggers and maybe use the gum when they have a strong craving. Patients' concern about restrictive rules to leave the floor is to make a plan and to involve the care team, particularly the nursing staff, in that plan and make sure it works for everybody. And then check in to see how it's being implemented. Patient fears about being discharged to a rehab or nursing facility for antibiotics. There is potential to collaborate with the ID team to come up with a plan for completion of antibiotics and avoiding the SNF placement, and including how to optimize adherence. So I think we're not going to have time to get through the third case, which is about how to address ambivalence or to deal with patient ambivalence about changing their drug use. But the good news is that we're going to have time to talk about this topic and to really focus in on it in our last lecture, which is about harm reduction. So I'm going to skip through these slides, but do invite you to look at them. We'll share the slide deck. The final takeaway points are, provider and patient experiences influence one another. And we're often stuck in a negative feedback cycle, but there are things that we can do. Sometimes just small things can turn it into a positive feedback cycle and then reap ongoing rewards from that, particularly around just establishing trust and communication. Utilizing some of the trauma-informed approaches that we talked about can improve the experience for the whole care team as well as the patient and lead to better outcomes. Patients are entitled to non-stigmatizing and evidence-based substance use disorder care the same way they are with care for other medical conditions. And as part of that, we need to provide appropriate pain management when patients are in the hospital, and be knowledge enough to do that, especially among patients who are on medications for opioid use disorder and have risk for opioid withdrawal. So I just want to acknowledge the person who developed a lot of the content for this talk, Juliana Wallace. And there are references that are here and a whole nother page here that encourage you to peruse and to reach out to us at this HBOT study at nyulangone.org if you have questions or having any trouble accessing any of those resources. So it's 1 o'clock, but we need to review just what to do for the CME. Do you want to cover that, Aditya?
Yes, thank you. So the CME credits will be open until tomorrow morning. So please, if you need to claim it, please try and do that as soon as possible. Thank you.
And where do we go to claim it?
There's a link left in the chat, which is supposed to take you to some sort of evaluation form, which takes about a minute before you can access the CME credit.
Great.
Thank you.
Well, thanks everyone for joining today, and we look forward to seeing you again in 2 weeks for the 7th of 8 lectures. Feel free to email us at the hbot@nyulangone.org email that was up, and I'll hang out for a few minutes. Our team will hang out for a few minutes if folks have questions or anything they want to chat about. But the rest of you, you're free to go. And thanks again for joining.